Thanks very much, Joe, and thanks very much for the organizers of this course to invite me back. It's always enjoyable to return back to your intellectual home, as I did my fellowship at the Brigham so many years ago, I don't want to admit. Well, the topic of discussion this morning is the landmark sprint trial, which I must say is arguably the most important trial ever done in hypertension since the original studies in the 1960s that virtually destroyed the concept of the essential part of hypertension, the VA studies, which transformed the whole field. I'm going to discuss SPRINT in three ways. First, describe the trial itself. Second, tell you how this has impacted clinical practice guidelines, and then a final brief discussion of the post-hoc analysis of the SPRINT trial itself, which I think will probably continue for another decade because they have an immense amount of data. I have nothing to disclose. However, I do want to express my appreciation to George Thomas at the Cleveland Clinic for allowing me to use some of the images in this presentation. I'll begin with a case. This is an 80-year-old woman who's referred to you for advice concerning her blood pressure control. She's a very healthy and active woman with only a little bit of arthritis and a painful hip. Her blood pressure taken in the office by a nurse is 144/60 millimeters of mercury, and her pulse is 72 and regular. She has a few abnormalities in the physical examination, but they're trivial. She doesn't have diabetes. Her serum creatinine is 1.05 with an eGFR of 50, so technically she does have CKD. However, urinalysis is negative for blood and protein, and her lipid parameters are very good. Given this scenario, I'd like you to consider a question as to which one of the following would you now recommend. I'm not asking you to answer this right now. I will come back to this at the end of the talk. Start a thiazide, start an ARB, initiate a DASH-style diet, or start a beta-adrenergic blocker. I could have had 4 or 5 other options, but I chose these 4 just to make it a fairly simple question. So keep this in mind, and we'll return to this at the end. The outline I've already given you, 3 parts: description of SPRINT, guidelines built upon the SPRINT findings, and post-hoc SPRINT studies. So SPRINT was published in 2015, and there have now been numerous publications derived from SPRINT since that time, and I expect that this will continue for many years to come. So SPRINT is a gift that keeps on giving, and I expect that we will learn a lot more about hypertension as a result of these analyses. The general design of the SPRINT trial is probably pretty familiar to you. It was designed to examine the effect of a more intensive high blood pressure treatment than was recommended at the time the trial was designed. It was randomized to a target systolic blood pressure of either less than 120 with intensive management, or to a goal systolic blood pressure of less than 140 with standard treatment. The blood pressure measurement in SPRINT is extremely important as it differs from the standard way of measuring blood pressure in the office. The values used to qualify and for the goals was a mean of 3 measurements in the office in the seated position After 5 minutes of quiet rest by an automated oscillometric system, a physician or a nurse was not required to be present. This is the device that was used for the measurement of blood pressure. It's Omron Model 907. Don't hold stock. I don't have any investments in this company, and there are many other oscillometric devices that can be used. This was not a wrist device. This was an upper arm oscillometric device. The primary endpoint of the trial was a composite endpoint to increase the event rates: myocardial infarction, acute coronary syndrome, stroke, congestive heart failure, or death from cardiovascular disease. Very importantly for this audience, the SPRINT trial was not a renal endpoint study. These patients who were admitted were older, over the age of 50. They had to have an elevated systolic pressure above 130, and most of them were on treatment at the time they were admitted to the trial, and they had to have some additional cardiovascular risk. They could have chronic kidney disease so long as the GFR estimated by creatinine was not less than 20. The exclusions for the trial, basically because of safety and ethics, was prior stroke, the presence of diabetes mellitus and polycystic kidney disease, as well as congestive heart failure, and as I mentioned, overt chronic kidney disease with an eGFR less than 60 and a systolic blood pressure over 180. So 9,361 patients were randomized, about equally between the two arms. No patient had diabetes. 91% were already on treatment, and CKD was present in about 30% of the patients, but this was mild CKD in most patients with an average urinary albumin to creatinine ratio of 43 milligrams per gram. 30% of the patients were African Americans. They were older, average age 68. 22% had pre-existing cardiovascular disease, so SPRINT enrolled high-risk populations of patients, not low-risk patients. The follow-up was only 3.26 years because the trial was stopped prematurely for efficacy. The original design was to have a 5-year trial. There was good separation of blood pressure between the standard and the intensive care, and this continued throughout the trial duration of 3.26 years. And as you all know, and the reason the study was discontinued prematurely is that there was a clear separation in the primary outcome between the two arms of the trial, favoring the intensive arm of the trial. And the number needed to treat in order to avoid a single composite event was 61 patients followed over 3.2 years. Now, there were a number of primary and secondary outcomes studied. I've already given you the data with the composite outcome, which was the primary endpoint, but there were other individual outcomes that were examined. And there was no difference in myocardial infarction, acute coronary syndrome, or stroke between the two groups. The main difference that drove the composite primary outcome difference was congestive heart failure and all-cause cardiovascular death and all-cause mortality. This is worth remembering, and I'll come back to this in some of the post-hoc trial studies which examine some of these individual outcomes. Now, for nephrologists, the subgroup analysis is important, and this forest plot shows the subgroup analysis of the impact in terms of the hazard ratio of the events in patients with and without chronic kidney disease. And in fact, in patients without chronic kidney disease, the effect on the primary outcome was greater. Obviously, these are hypothesis-generating analyses because this is a secondary outcome. Now let's examine more carefully the renal outcomes in patients who had CKD at the baseline. This was 2,646 patients, and the outcome examined here was the first occurrence of a reduction in eGFR by 50% or more from baseline, or the development of dialysis or transplantation requirements. The composite renal outcome was not different between the two studies, nor was there a difference in the 50% decline in CKD dialysis transplantation in patients who had CKD at baseline. However, in patients who did not have CKD at baseline, there was a significant difference in the renal outcomes measured as a decline in GFR to less than 60, or the new onset of albumin, or the development of a GFR less than 60. And that was a rather impressive hazard ratio of 3.5, indicating a substantial difference in the outcome of intensive care versus standard care in patients without CKD. So let's look at some of the other serious adverse events found in this trial during follow-up, examining the intensive versus the standard group, and looking at the hazard ratio with the standard group as the reference value. Hypotension was more common, not surprisingly, in the intensive care. Syncope, falls were also, syncope was also significantly different, but falls and bradycardia were not. Electrolyte abnormalities, predominantly hyperkalemia, were seen more frequently, and episodes of acute kidney injury, defined by a rise in serum creatinine, were more common in the intensive care group. So the main conclusions of SPRINT were that in an elderly, non-diabetic subjects without a prior history of stroke, but with increased cardiovascular risk, intensive blood pressure lowering improves both cardiovascular mortality, mainly from congestive heart failure, and all-cause mortality, at least for up to 3+ years of follow-up. In a subgroup analysis, however, no benefits were seen for the primary cardiovascular outcomes in subjects with CKD at baseline. Now remember, there were only 22% of the patients who had CKD at baseline in this trial, so it may have been underpowered to show a benefit. There were no benefits found on CKD progression in patients with CKD at baseline, and there was a potential harmful effect on eGFR seen in those without CKD at baseline. No clear-cut effects on albuminuria were observed. Adverse events were more common in the intensive care. Now that's where SPRINT left us when it was published in 2015. And soon thereafter, the findings of SPRINT were incorporated into clinical practice guidelines. And in the second part of this talk, I'd like to describe some of those guideline changes. Now, guidelines in hypertension have a long history, dating back to 1976, when the Joint National Committee on the Management of Hypertension issued their first report, which was 6 pages in length. The last formal JNC report was issued in 2003 and it was 47 pages long. JNC 8, the panel was appointed in 2008. However, it was disbanded in 2013, and some of the panel members proceeded with an independent publication outside of the JMC umbrella in 2014 as an evidence-based guideline, one of the first of the evidence-based guidelines in hypertension. Subsequently, the American College of Cardiology and the American Heart Association were given charge for developing U.S. hypertension guidelines, which they did, and developed a report published in 2017. But the most immediate guideline preceding the 2017 American Heart Association, American College of Cardiology guideline was the JNC 8 panel guideline, which I've already stated was evidence-based. And in that recommendation, they adopted a target goal in the general adult population less than age 60 of 140/90. They had both systolic and diastolic goal recommendations, and they added a recommendation that was age adapted, in that the systolic blood pressure could be as high as 150 in patients over the age of 60. The blood pressure target goal in the high cardiovascular disease groups were the same as the general population, so this was not a risk-adapted goal recommendation. And the blood pressure target goal in both chronic kidney disease and diabetes mellitus was the same as the general population. However, the single difference, there was no age adjustment. So the same 140/90 applied to patients of all diseases. Now, in 2017, the ACC-AHA guideline was published in JAMA, and it was developed by a panel represented by numerous societies and organizations, except the American Society of Nephrology, KDIGO, the National Kidney Foundation, the American College of Physicians, or the American Academy of Family Practice. And to no one's surprise, many of these non-included organizations have never endorsed the American Heart Association ACC guidelines, particularly the American College of Physicians and the American Academy of Family Practice. So I want to just give you a synopsis of this 50-page document dealing with diagnosis, when to start treatment, and the management. Now, looking at JNC 7, remember JNC 8 was never an official guideline. It was a panel publication. There were differences between the JNC 7 2003 and the 2017 in terms of the definition of hypertension. The 2017 ACC-AHA decided to call stage 1 hypertension with a systolic blood pressure between 130 to 139, or a diastolic blood pressure between 80 and 89. Previously, that would have been called prehypertension. And then, of course, there were additional stages of hypertension above that were different from JNC 7. Now, this change in the diagnosis of hypertension led to a sudden, dramatic increase in the number of patients subjects, not patients, in the United States who now had a new disease, hypertension, who were previously healthy. 31 million patients now acquired a new diagnosis of hypertension as a result of these new goals. Now, most of these patients were believed to be diagnosed and managed by the primary care physician, about 27 million. And most of the management of these patients would be by lifestyle modification, diet, exercise, avoidance of alcohol, etc., and 4 million by drugs. But this means a net increase in the number of patients requiring pharmacologic management of hypertension by about 4 million. Now remember, the blood pressure measurement in the SPRINT trial, which served as the basis for much of the change in the recommendation, were basically out-of-office measurement of blood pressure. Even though they may have been done at rest, the physician and the nurse was not present, and they were utilized an oscillometric method. And it has been firmly established now by subsequent studies that observed in the office blood pressure measurements overestimates automated oscillometric systolic blood pressure by about 10 millimeters of mercury. So an in-office blood pressure of 140 systolic translates to about a 130 millimeter of mercury blood pressure when unobserved oscillometric measurements are used. In addition, it is now well known that if you want to classify hypertension according to its subtypes, you must do ambulatory blood pressure monitoring, and there are a variety of patterns of blood pressure that have important prognostic and therapeutic implications. There are normotensive patients, sustained hypertension, masked hypertension, and white coat hypertension. These are subcategories of blood pressure, phenotypes, if you will, that can be determined by ambulatory blood pressure, which requires blood pressure measurements throughout a 24-hour cycle. These subtypes have important prognostic implications, as if you compare these subtypes to normotension as the reference, white coat hypertension, sustained hypertension, and most markedly masked hypertension, classified by ambulatory blood pressure, markedly increases the risk of cardiovascular disease events and mortality. Now, the blood pressure thresholds for treatment in the newest version of the guidelines indicates that between normotension and 130 to 139, lifestyle modifications are the primary approach. I'll discuss what those are in a moment. But if there is a high cardiovascular risk, above 10%, 10-year atherosclerotic cardiovascular disease risk, then pharmacologic management is recommended, or if the patient has diabetes or chronic kidney disease or is elderly, over 65. These recommendations, shown in orange in this diagram, directly follow the findings in SPRINT. Now, here are some of the non-pharmacologic measurements or non-pharmacologic management approaches to hypertension and their approximate effect on systolic blood pressure in hypertensive patients. Weight loss, a healthy diet as exemplified by the DASH vegetable fruit diet, reduced sodium chloride intake, increased potassium intake, aerobic dynamic resistance or isometric exercise, and reduced alcohol intake. I've not added smoking here because smoking is a general phenomenon. No one would recommend smoking in any circumstance. The healthy diet with DASH has the most prominent effect on systolic blood pressure in hypertensive subjects and should probably be the first, although not only, recommended approach to non-pharmacologic management. Now, I've discussed the blood pressure goals for the management of hypertension after you decide which patient should be treated by which method, and it depends upon whether they have known cardiovascular disease or an elevated risk of atherosclerotic cardiovascular disease. If either are present, then a blood pressure target of 130/80 is recommended by the ACC based on moderate evidence for systolic blood pressure and expert opinion for the diastolic blood pressure goal. For adults without any additional marker of cardiovascular risk, a blood pressure target of 130/80 might be reasonable, but the evidence is not as strong. And in fact, the recommendations are weak. In terms of the choice of initial medication type, the evidence is quite strong and high-quality evidence for first-line treatment with thiazide diuretics, CCB, and ACE inhibitors or ARB. There may be some modifications in these depending upon race and ethnicity, and there are some caveats that you should not use an ACE inhibitor and an ARB concomitantly or with a renin inhibitor. In patients with chronic kidney disease, the ACC AHA guidelines suggested a goal of 130/80. This is based for systolic blood pressure only on moderate evidence, not excellent evidence, and the diastolic blood pressure goal is expert opinion only. In patients with albuminuria above 300 milligrams per day, a treatment with an ACE inhibitor is first choice. In patients with hypertension and more advanced forms of CKD, an ARB may be reasonable if an ACE inhibitor is not tolerated, but the evidence underlying this is rather weak. In patients who have diabetes mellitus, again, the treatment goal is 130/80 because they are at high risk for cardiovascular disease, and the use of diuretics, ACE inhibitors, ARB, and in some instances, CCBs are thought to be beneficial. Now, there have been some additional analyses following the publication of SPRINT. Here is one in which the data from SPRINT, which was non-diabetic, was combined with ACCORD, which was diabetic and which did examine an aggressive, intensive approach versus a standard of treatment approach. And the event rate of cardiovascular disease, particularly congestive heart failure, is reduced in both diabetics and non-diabetic subjects with aggressive management. Here is the data showing the difference with and without diabetes. The ACCORD study showed a rise in incident chronic kidney disease with the intensive management arm, a 5.9% increase in CKD. And in SPRINT without diabetes, there was also an increase in incident CKD, largely the result of a decline in GFR when treatment was initiated, but the magnitude of the difference was less. Nevertheless, these are both significant increases, not decreases, in the risk of CKD with intensive management of hypertension. Now, I alluded earlier to the JNC 8 panel recommendations that divided patients according to age. This subdivision according to age was not adopted by the ACC, AHA, and they recommended a goal of less than 130 millimeters of mercury for ambulatory community living adults over the age of 65. However, if they have a lot of comorbidity and a limited life expectancy, this goal may not be the best one to be adopted. So in conclusion about the American Heart Association ACC guidelines, I want to stress a few caveats. I mentioned many of them in the previous comments. First of all, these guidelines have not been yet endorsed by the American College of Physicians or the American Association of Family Practice, two major organizations representing primary care physicians. The guidelines are not applicable to practices using office-based, non-automated blood pressure measurements. The findings and guidelines are largely based on expert opinion and consensus, and the guidelines ignore the dangers of a diastolic blood pressure less than 60 to 65 millimeters of mercury in diabetes mellitus and cardiovascular disease, in which it has been clearly shown that a diastolic blood pressure less than these values promotes rather than prevents cardiovascular events. The studies are probably not very applicable to low-risk subjects in which a target blood pressure of less than 140/90 is reasonable, and it may not be appropriate to push this value down to the 130/90, 80 millimeters of mercury. Very importantly for this audience, none of the American Heart Association ACC guidelines apply to patients with CKD and an eGFR less than 20 or 30 millimeters of mercury. You cannot apply the same criteria in this group because there is no benefit, and the risks may be substantial. Now, there is a societal burden issue because if you adopt these guidelines and universally apply them, there will be 31 million new hypertensives, and who is going to take care of them? The major burden will be on the primary care physician. Now, I mentioned the diastolic blood pressure issue. There is a very definite U-shaped curve in diastolic blood pressure. In terms of the hazard ratio for death or events, and the lowest diastolic blood pressure associated with the lowest risk of CVD is somewhere between 60 and 70 millimeters of mercury. Below that value, the risk rises, and above that value, particularly above 90, the risk increases. Now, not everyone has agreed with the ACC-AHA guidelines. If you go around the world, every country has developed their own guidelines. The European Society of Hypertension, here I show the Canadian guidelines just north of our border, and they're quite different from the guidelines as developed by the American Heart Association. So we have a lot of lack of synchrony between guidelines. which generates confusion. And there is no harmonization of guidelines on a global basis. I suspect that some of this may disappear with time, but at the moment there is, unfortunately, a lot of disagreement between the guidelines. Now, there have been a lot of written comments about SPRINT and the American Heart Association guidelines in terms of their relevance for nephrology. Very germane to this audience are two papers, which I've given here, a paper by Kovac et al. And one by Cherto et al., both arriving at a similar conclusion that SPRINT reaffirms the need for blood pressure control, but is not a sufficient standalone for nephrologists treating CKD with hypertension in the community. And Cherto adopts a very interesting phrase, determining the optimal blood pressure targets for all patients with CKD will likely take another 1 or 2 decades of effort. It is a marathon, not a sprint. So in conclusion, for this part 1 and part 2, there is no doubt that SPRINT and the accompanying guidelines represent a major advance in our understanding of the diagnosis and management in the general adult community, but it has less relevance for subjects with CKD. There is virtually unanimous agreement of the importance of accurate measurement of blood pressure, predominantly by out-of-office automated blood pressure management, and in fact, measuring blood pressure by a nurse in the office with non-automated equipment should be eliminated, should no longer be the standard of care. A risk-adapted approach using conventional measures of risk like the Framingham Risk Score or others may be a very appropriate step in making decisions about treatment, since one size does not fit all, and applying SPRINT and the guidelines to the community as a whole will represent a major challenge. Now, I've added a very brief part 3 to my talk. I didn't consider this important when I prepared the original slides for this presentation, but I felt that it would be important to add them, so I've only prepared one slide because these are post hoc analysis of the SPRINT data that might have clinical meaning. SPRINT Mind, published in JAMA this year, clearly shows that intense blood pressure control reduces the onset of mild cognitive impairment, but not probable dementia. So in your hypertensive patients who are deeply concerned about the development of cognitive impairment, intensive blood pressure control might be something you should consider. In the SPRINT Heart post-hoc trial, both intensive and standard blood pressure control reduced left ventricular mass equally. But there was a big difference in congestive heart failure. Why is this? We don't know. But the left ventricular mass will shrink with either intensive or standard blood pressure control. The SPRINT diastolic blood pressure study has clearly shown that a level of between 60 and 70 millimeters of mercury diastolic blood pressure is safe. Below 60 is not safe and increases the risk of events. SPRINT cardiovascular disease and CKD has shown a reduced risk of cardiovascular events is not attenuated at all by a decline of GFR less than or greater than 20%. And finally, In a combination analysis of ASK, MDRD, ACCORD, and SPRINT, chronic kidney disease with an eGFR greater than 60, this is largely albuminuric patients, management of high blood pressure in a more intensive fashion is associated with a reduced all-cause mortality risk. This is not seen in patients with eGFRs less than 60. So let's return to the case. I'm not going to go over the preamble here of the presentation, but I will provide you with the answer, and I think it should be obvious from my discussions that in an elderly patient with low risk of cardiovascular disease, even though the patient has an eGFR less than 60, there is no albuminuria. This patient is an ideal candidate for not pharmacologic management, but non-pharmacologic management. And the DASH-style diet and emphasizing vegetable and fruit and low salt would be the correct answer. So thank you very much for your attention to this talk. I appreciate it.